Recent headlines often frame psilocybin as an effortless, standalone miracle cure for the brain. But every breakthrough observed in clinical trials depends on a highly structured, intensely demanding psychiatric process. The chemical is only the starting point for weeks of professional intervention. Public understanding remains heavily clouded by the cultural and political baggage of the 1960s, making it difficult to separate recreational use from medical science. We need to look at what the clinical science actually requires to achieve these results, and the specific toll it takes on the patient. Evaluating psilocybin as a medical treatment requires us to examine the intense biological and psychological investments actually required to see a result. Psilocybin acts by binding to a specific serotonin receptor in the brain, known as 5-HT2A, triggering an acute, explosive flash of neural activity. Compare this massive burst to standard daily antidepressants, like SSRIs, which rely on a slow, continuous trickle of molecules over time. To maintain clinical accuracy, we are only analyzing data from controlled human clinical trials, leaving aside all recreational anecdotes. We will use this evidence key for every claim: Tier 1 in green for strong human data, Tier 2 in yellow for promising early results, and Tier 3 in gray for preclinical theories. Filtering for proven human data is the only way to understand who this treatment can actually help. This pulsing network represents the default mode network, or DMN. In patients with depression, this system often gets trapped in rigid, repetitive thinking loops. When psilocybin hits those 5-HT2A receptors, it temporarily scrambles that network. On clinical brain scans, this manifests as a massive, immediate surge in neuroplasticity. Patients often describe the subjective experience as ego dissolution. Their strict sense of self drops away, allowing them to view entrenched trauma from a disconnected, non-judgmental stance. This rapid breakdown of mental boundaries causes intense panic or existential dread in some patients, especially if experienced outside of a controlled clinical environment. The drug creates a window of malleability. It is during this temporary state that the patient is able to perform the actual psychological work required for recovery. That work occurs within substance-assisted psychotherapy, a container designed to safely manage the patient's highly vulnerable state. The process begins with weeks of drug-free preparation sessions, mapping out psychological goals. On dosing day, the patient undergoes an 8-hour supervised session, where core emotional breakthroughs occur. Finally, an integration phase of follow-up therapy translates insights into permanent changes. This protocol demands dozens of hours of clinical time and significant emotional energy. It is a high-friction process compared to simply taking a daily pill. Skipping this exhaustive therapeutic container transforms a clinically successful treatment into an unpredictable recreational trip. We applied our Tier 1 strong evidence filter to see where this massive investment of time and energy actually pays off. Treatment-resistant depression shows strong Tier 1 evidence, with patients experiencing rapid and sustained symptom reduction. We also see Tier 1 results for end-of-life anxiety, where palliative care patients reported significant relief from existential distress. For addiction disorders like heavy smoking or alcohol use, the data shows success in breaking the repetitive behavioral loops associated with the disease. These conditions all share a specific characteristic. They are disorders of rigid, stuck mental habits that require forced plasticity to break. While the outcomes for these specific, rigid conditions are effective, the data clarifies that psilocybin is a targeted tool, not a universal solution for all mental health issues. The clinical science is equally clear about who should avoid this treatment. This matrix maps the risk. While depression is a Tier 1 fit, conditions lacking mental boundaries, like schizophrenia, are strictly contraindicated. Further breaking down reality filter feels dangerous. Data also rejects this intense protocol for casual wellness or anyone seeking a passive fix. These scientific boundaries will continue to be tested and refined as researchers follow the rigorous evidence gathered over the coming years. The clinical power of this treatment lies in the demanding, collaborative psychotherapy that the substance enables. Recovery depends on the fusion of chemical malleability and professional clinical